I'd like to thank the team at the Task Force, Children Without Worms and the COR-NTD Secretariat for their support bringing this session to life. In particular, enormous thanks to Chelsea Toledo, Girisha Shankar and Rubina Imtiaz. Over to you, Pauline.
Thank you, Justine. Good morning and good afternoon, everybody. Thank you all for showing such great interest in this session. I was really impressed to see the registration. My name is Pauline Mwinzi, and I am the Schistosomiasis STH focal point at the WHO Regional Office for Africa, and I will be co-chairing this session. Water, sanitation, and hygiene, WaSH, are critical in the prevention and care for all of the NTDs we've listed for control, elimination, or eradication. But focused efforts on WaSH are needed more urgently for those NTDs where transmission is most closely linked to poor WaSH conditions, such as in the case of soil-transmitted helminthiosis, schistosomiasis, trachoma, and also lymphatic filariasis. Now, provision of safe water, sanitation, and hygiene was one of the key interventions within the previous global NTD roadmap. And yet during the previous decade, the WaSH component of the strategy did not receive as much attention as we had hoped. And from the start of the last decade, as the NTD community, we had grappled with what needs to be done to make WaSH activities a reality in NTD programs. Given that ensuring access to clean water, appreciable levels of sanitation and hygiene is mostly beyond the expertise and funding levels that is available in NTD programs. And so by 2015, WHO put together a strategy to mobilize WaSH and NTD sectors to work together. And this called for WaSH funders and implementers to target NTD endemic areas and deliver programs that maximize the effectiveness of WaSH interventions for control and elimination. And in the new roadmap 2030, where intensified cross-cutting approaches is one of the key 3 pillars of the roadmap, WaSH is one of the key strategies where coordinated efforts across sectors is needed. But in order to appropriately mobilize these other actors into the WaSH agenda, and especially the funders, we need evidence to encourage the needed investments. And this is where synthesizing available data is needed urgently, as well as identifying the operational research questions to contribute to the NTD Roadmap 2030 WaSH Research Agenda, which appreciably the NNN WaSH working group is helping to develop. So I want to thank the colleagues who've worked together to put together this session, all the speakers, and all of you have shown great interest to contribute to the progress in addressing WaSH evidence strengthening in NTD programs. The presentations lined up in this session are examples from some of the WaSH and NTD actors showing emerging successes and challenges. And so I now wish to hand over to Yael to introduce the speakers. Thank you very much.
Thank you so much, Pauline, for this fantastic introduction, and I'm really excited about this session. So I have the honor of introducing our first speaker. She's Dr. Susanna Vasneri, and a long-standing champion for WaSH and NTDs integration. She's an associate professor at the University of New South Wales. She has expertise in a whole range of fields, including biochemistry, neurosciences, molecular parasitology, health policy, and field epidemiology. And she's lived and worked in more than 10 countries in all continents. Her research on NTD uses intervention studies to generate evidence for policy changes for more effective and sustainable disease control strategies. And with that introduction, Susanna, over to you.
Thank you very much, everybody. Thanks a lot for the opportunity to present the evidence on the role of WaSH interventions in reducing infections with soil-transmitted helminths. I assume everybody's hearing me okay, so I'll keep going. So I'll just briefly remind you of the STH life cycle, as it has implications for control, as Pauline just said. So in short, infected individuals contaminate soil with feces containing helminth eggs. Then other individuals get infected when they consume eggs through contaminated food or hands or by larvae penetrating their skin. And then eggs develop into mature worms in the gut, and female worms start laying eggs again. So, as you know, preventive chemotherapy with anti-helminthic drugs, mainly targeting school-age children and other groups at risk, is the main strategy for STH control. However, in the absence of environmental changes, reinfections occur rapidly, and therefore deworming needs to be repeated. Therefore, WaSH interventions, so water, sanitation, and hygiene interventions, have been put forward as a strategy for a sustainable control of STH. So sanitation or appropriate sanitation reduces environmental contamination with feces, whereas hygiene interventions like wearing shoes or hand washing reduce individual exposure. And therefore, effective WaSH interventions can prevent infections and reinfections, and therefore reduce transmission. You may be aware that there has been a remarkable scale-up in deworming programs for STH control in the last decade. Indeed, the 2016 Global Burden of Disease study estimated that between 1990 and 2016, there was a significant reduction in the disability adjusted life years caused by STH, depending or varying according to the different STH species. And these reductions likely reflect the direct impact of a scale-up in deworming programs, possibly also economic development and the consequent increased access to improved WaSH infrastructure and use also contributed to the reduction in the STH burden that we have seen. However, there is still the need to improve STH control programs. STH will affect 900 million people globally. Albendazole and mebendazole are not effective or very effective against Trichuris recurrens, Strongyloides stercoralis, and LFMDA, that also includes albendazole, is being scaled down in some areas due to the elimination of LF. So it is in this context that our session is highly relevant. And so now I will review the evidence on the impact of WaSH interventions on STH infections. And first I will summarize and discuss the existing published trials. I will mention that part of this presentation reflects discussions held during an expert meeting convened by the Gates Foundation and CIF in London in 2018 that was later published. Then I will also mention the role of mathematical modeling in predicting the impact of WaSH interventions, particularly useful for long-term impacts. And I will refer to the work done by Luke Goffeng. So let's start reviewing the interventions or the intervention studies that have been published so far. This table summarizes the 4 school-based intervention trials that have been published. As you can see, they've been done in different geographic locations, and they differ in quite a variety of aspects, including follow-up, time, and the intervention that took place. The 2 that focused on hygiene promotion had some impact on STH, particularly on intensity of Ascaris lumbricoides. There were other 2 trials that included more comprehensive combined WaSH interventions. One reported a limited impact on Ascaris lumbricoides by Matt Freeman, here present, whereas the other reported no impact, also by Matt and this group. This table now summarizes the 12 community intervention studies, including 2 that are pilot non-randomized studies. And again, you can see they took place in a variety of geographical locations and had quite different follow-up times. And again, quite different interventions as well. So one promoting hand washing and nail clipping reported lower reinfection for any STH. two trials in India on sanitation that followed the government-led intervention to end open defecation did not report an impact. However, coverage of latrines was low. There has been indeed a recent pilot study with a sanitation intervention that does report impact on STH. Then there were two very comprehensive WaSH trials testing the impact of individual and combined WaSH interventions and nutrition, and done in two different settings. And they detected an impact mainly in the arms that contained a water intervention. Finally, there was a trial comparing the combined impact of MDA and WaSH to MDA alone. That was by myself and Archie Clemens and others, and that did not see a significant impact on STH infections. And that was similar to another pilot study testing a similar intervention. Okay, so in short, or in summary, I've listed here again, sorry, the interventions that were used in these 12 studies that have been published. And you can see that most were unique to each trial. There's only been WaSH benefits that used a similar set of interventions across two different countries. And of the 8 community trials, there were 4 that did not detect an impact of WaSH in STH infections. On the other hand, of the 4 school interventions, most detected some level of impact, albeit a bit limited to intensity reduction mostly. Okay, how can we explain such heterogeneity in findings? I'd like to group these kind of possible explanations ahead of our discussion later into broad categories. So one has to do with the variety of intervention designs that I just described, making it difficult to compare trials. We should also say, obviously, that as you know, or most of you know, WaSH interventions are quite complex, particularly sanitation and water access that require significant infrastructure, and also behavior change interventions are quite difficult to implement. Of note is that trials of simple interventions like nail clipping suggest that they may have an important role. As I mentioned further, WaSH improvements also require behavior change, and in general, for WaSH to have an impact, interventions need to achieve high coverage and sustained use, which was not always reported in the previous studies. So if coverage and use is not high enough, then those interventions won't be enough to decrease contamination or exposure. On the other hand, the pre-existing STH species and their prevalence seem to also be important, not surprisingly. Looking at the published studies, it seems that the impact is more readily noticeable in Ascaris lumbricoides, and also in settings where there is lower prevalence of STH at the beginning due to ongoing deworming programs. And finally, the 1 to 2 year typical trial follow-up period may not be long enough for the impact of WaSH to be detected. So here's where mathematical modeling can help. So it can help predict the impact of individual WaSH components or combined WaSH interventions on individual STH species and over longer period of times. And it can be used to test hypotheses or to confirm, to help explain the results of experimental approaches. So when we became aware of the WaSH for Worms trial, Archie Clemens and I began collaborating with Luc Goffeng to try to explain the lack of impact of our trial that looked at MDA and WaSH intervention relative to MDA alone. As I said, we didn't see any additional benefit of adding WaSH to an MDA intervention. So Luc Goffeng had previously developed the worm-sim model that had been used to predict the impact of preventive chemotherapy on STH infections. And he then modified his model to predict the impact of individual and combined WaSH modalities on STH infections. So both hygiene, sanitation, individually or together. These, I'm just showing here an example. So the model predicted what we saw in the trial. So community, so this is Ascaris hookworm, and you can see that community deworming every 6 months for 2 years, which was what we did in our trial, was very effective in bringing STH prevalence down over that 2-year period. And you can also see by looking at the sanitation red line or the hygiene blue line or the combined intervention purple line that the model predicts a negligible additional impact of any of these interventions compared to the decrease that is achieved by MDA alone. So I have to say this is, again, community deworming every 6 months for 2 years. So it confirmed our trial results, which was sad but reassuring. On the other hand, we further used the model to predict the impact of WaSH interventions in other contexts. So I'll just point you here for the last, for the bottom panel. So the model predicts that WaSH interventions have an important role when preventive chemotherapy programs targeting school children are stopped. So you can see here that school deworming, here is annual school deworming for 5 years is effective in reducing STH prevalence. But you can see that when that prevalence reaches a lower level and PC programs are stopped, prevalence will bounce back to almost the same levels as pre-intervention, pre-deworming programs levels. However, if you have WaSH in place, then either just sanitation or even just or hygiene alone or the two combined, you can see that the rebound of infection will not take place. Okay, so I'd like to conclude now, just going back to the previous thoughts in terms of what additional evidence we may need to further strengthen the message around the role of WaSH for STH control. I believe that on one hand, there are operational research needs regarding the intervention design. So namely, it is not clear what are the individual modalities of WaSH that have the higher impact, together with a need to further explore the role of simple, between inverted commas, simple interventions like fingernail clipping or shoe wearing. We also are not completely aware of what are the coverage and use thresholds that are needed for an impact of WaSH to be noticeable. And finally, there is a need to identify standard strategies that allow implementers to achieve and sustain high levels of coverage and use of WaSH interventions. One final aspect has to do with how we measure impact of WaSH. So we usually, as I mentioned in these trials, we measure the impact of the interventions by measuring STH prevalence at the beginning and at the end of the trial and the intensity of infection. However, our feeling is that trials should also include an assessment of exposure associated with that intervention. That is, we should also be measuring the presence of STH in the environment. And I believe this has only been done in one trial recently. I think is work by Amy Pickering and their group. So in conclusion, improvements in WaSH will continue to be a major policy objective given the impact on other diseases as well as on well-being more broadly. For STH, clearly preventive chemotherapy will continue to have a major role in reducing prevalence and intensity of infection quickly, and WaSH has then an important role in preventing reinfection, particularly post-preventive chemotherapy programs. And we need stronger evidence that can guide clear guidelines regarding what specific WaSH interventions and at what coverage levels, and when they should be emphasized. Thank you very much for listening. Also, thanks. I'd like to acknowledge the co-authors and colleagues present at that London meeting I mentioned, particularly Amy Mickering and Simon Brooker, and also Aisling Byrne for her support in the preparation of this presentation. Thank you.
Thank you so much, Susanna, for that fantastic presentation, really comprehensive. I think we have a couple of minutes to take one question. So I can see there's a great question from Teresa Baird from CBM, another member of the WaSH working group. She is asking, is the proximity or ease of access to WaSH recorded in any of the studies?
I'm not sure if that question refers to the proximity to water sources.
I think it refers to either WaSH, either water or sanitation.
I mean, I believe that, yes, so I believe all the interventions that had to do with promoting sanitation, they promoted individual sanitation when there were community interventions, or in schools they promoted or built school latrines. So yes, so that was guaranteed. And in terms of water interventions, a similar aspect. So either the intervention provided an easier access to a water source, or a closer access to a water source, or and also to hand washing facilities. So it depends on the intervention, but in general, yes. But not necessarily for forever, right? Let's say springs may dry up, or latrines can stop working. So there is definitely an issue in terms of access potentially in the long run.
Wonderful. Thank you so much for that. I think we will now move on to our next speaker, but please do keep the questions coming. Hopefully some of them will be answered by other presentations, and if not, we will try and come back to them later on. So thank you, Susanna, and we'll move on to Dr. Matthew Freeman. Matt is an associate professor in the Gangarosa Department of Environmental Health at the Rollins School of Public Health at Emory. He has joint appointments in epidemiology and global health, and is a fellow at Emory's Global Health Institute. And I can personally say that Matt has been a real champion to the cause of WaSH and NTDs collaborative research for almost a decade. Some of us will remember a couple of pivotal meetings starting in 2012 that he's helped to lead. His research looks at designing theory-informed interventions of WaSH technologies and behaviors, quantifying impacts through rigorous methodologies, and understanding drivers of behavior change and program sustainability. So a very easy job. Matt works on NTDs quite a lot, and he serves on the Global STH Advisory Committee and supports WHO on various issues related to hand washing, hygiene, trachoma control, and STH control. So without further ado, over to you, Matt.
Thanks so much. Hopefully you're seeing my full screen. And let me say, it's a pleasure to have some level of normalcy and have a meeting talking about WaSH and NTDs. And thanks for hosting this event to the London Center for NTDs. So I'm going to build, I think, on what Susanna just was discussing. We'll maybe take a step broader and focus on trachoma and STH. And I'm going to review some of the evidence and maybe pose some questions about how we really reach impact at scale with WaSH and NTDs. And this is, as all of you know on the call, it's kind of a tough nut to crack here. So I really want to pose 4 key questions. First is what NTDs are most impacted by WaSH? And I'll talk about that briefly because I think we're all aware of that. What is the biological plausibility for the impact of WaSH? What is the empirical evidence to support WaSH programming? And what do we really then need to know to achieve impact? And so I think about this as a kind of a causal chain of knowledge. So first, if we're designing a WaSH intervention, we want to understand, should it work? What's the plausibility? Then we want to know, could it work? Or what's the efficacy? What does it work in closed environments, like a drug trial? Third, does it work in the field? And I think as we'll kind of talk about, and as many of you know, this has really been the challenge of the WaSH sector, and we'll talk a little bit about that. And then, of course, to actually reach impact at scale, you really want to think about how this chain of evidence impacts policy and allows us to develop context-specific programs that can be replicated and scaled. So you're all familiar with the NTDs. I'm going to talk specifically about STH and trachoma, though there are several others that are WaSH related. And I just want to point out that WaSH is a complicated set of interventions that involve both the technologies and behaviors across these domains: water, sanitation, and hygiene. And in the water, in the WaSH sector, we think about water quality and water quantity. In sanitation, we're talking about this complicated use of toilets. There's the whole family using it, but also child disposal of feces. And then on the hygiene side, in the WaSH field, we're really talking about hand washing with soap, full stop. And there hasn't been a lot of movement on that needle. But I highlighted here some key behaviors that are NTD-specific WaSH behaviors that really are not promoted if you talk to folks in the WaSH sector. And that's shoe wearing, bathing in safe places that, of course, would be associated with schistosomiasis, and face washing associated with trachoma. So we have this challenge that the WaSH sector doesn't even mainstream some of these core behaviors that we really care about in terms of NTD control. This is a table from the WHO Global Burden of Disease from 2019, led by Annette Ustin. And I put this up here to highlight this second column here, the PAF, or population attributable fraction. And this was calculated by the team to think about, what could WaSH do? Okay, so what could WaSH do, and what are the then attributable deaths and DALYs associated with WaSH as it relates to NTDs? And so at the top, you can see schistosomiasis. So about 43% of the infection we calculated was related to poor WaSH conditions, resulting in over 1 million DALYs and 10,000 deaths. Trachoma and STH, well, we estimated that 100% of the deaths and DALYs for these diseases could be attributed to poor WaSH. And so that's really powerful, actually. We know we're not getting there in terms of the effectiveness studies, but the biological plausibility tells us, hey, these WaSH will control trachoma and STH completely. And I think that's just an important and powerful policy tool to bring to discussions at country level. What we really don't know is, what could WaSH control do? What could WaSH control in the real world in contrast with preventive chemotherapy? And so Susanna talked a bit about that, and there's some meta-analyses and reviews that are mostly observational studies. And looking at these, many of the recent and high quality studies are not included that Susanna talked about. And so just briefly, for trachoma, we think about kind of ocular nasal discharge and how it moves through fingers, fomites, and flies to a future victim. And looking at some of the studies that were available back in 2014, we saw a 33% reduction or lower trachoma associated with sanitation. For clean face, about a 60% less trachoma, 24% less trachoma for soap use, 35% less for towel use in bathing, and about 25% lower trachoma for bathing, sorry. And then really didn't have much on hand and hand hygiene at that time. On the STH side, each of these is showing the % odds reduction for different parameters. So in the green, sanitation access across hookworm, roundworm, whipworm, and kind of any STH. Hand washing showed very high high reductions. Shoe wearing, of course, really important for hookworm. Water quality and pipe water use. So again, these are all observational, mostly observational studies, some trials. But a follow-on study commissioned by the WHO for the sanitation guidelines found that using these kind of, again, using observational studies did show really substantial impacts of sanitation on STH, trachoma, and schistosomiasis. And then, of course, when you add these intervention studies, so these are now only studies where there's a trial, we get pretty much null results and almost nothing on schistosomiasis, and very low. You see on the final column, the grade score, kind of very low quality studies. So the challenge is really, as we know, getting these rigorous trials. We just completed the initial analysis on a Cochrane review, and this is hot off the presses, and you're the first ones to see some of these results, but these are all trials, and they include some really recent and rigorous studies, specifically out of the WaSH benefit study. And what we can see here is we do see a significant impact of the interventions on STH. So it's about a 14% reduction in the odds of STH, and it is statistically significant. When you break it down by different intervention types, education, single wash, or multiple wash down below, you don't see significant impacts, mostly because our confidence intervals are large. But I think it's nice to see this reduction. It's not a major. It maybe not something that's going to drive major funding towards WaSH from the NTD sector, but that's not really the point. I think the point is to show that when you do high quality studies that include WaSH, you can show reductions in STH, oftentimes above and beyond preventive chemotherapy. So coming back to what do we know, and bringing these questions back up. So I think we can definitively say the plausibility is there, and the efficacy is there, but the effectiveness is really lacking. And so what are some of the key gaps? And Susanna talked about this a little bit. This comes from the WHO guidelines on sanitation and health again. And sanitation specifically is complicated. There's multiple transmission routes. It's highly contextual to the site, and it involves this really complicated interplay of technologies and behaviors. And it's not just having a toilet, it's having a toilet and maintaining it and using it and upgrading it and actually recovering from the toilet becoming disused or destroyed through some kind of other challenge. And the review found that there are these key implementation challenges, for us to understand like what interventions are most appropriate for every given setting and how best to deliver these interventions. And also, as Susanna mentioned, the impact of a fecal and pathogen load in the environment. So understanding how these interventions actually clean up the environment. And this is a visual representation, again, of this issue of sanitation coverage. And what this is showing is on the y-axis relative risk for diarrhea. So reduction of each of these trials for diarrhea specifically. And then across the bottom, from dirty to clean, you can think of it as the magnitude of reduction of fecal exposure. And so what you're seeing here is as you go from dirty to clean, there's little or no change if you just make small improvements. But if you look at this at the right side of this graph, there's actually starts to be a nice curve. As you start to really clean up the environment, you really start to see major reductions in diarrheal disease. And so we looked at that with trachoma as part of a study, looking at across the top. This is prevalence ratio. So one line is no impact of, in this case, it's water, and then different quartiles of community coverage. right, what this is showing is the total effect of water in the gray circle, and the diamond shows the indirect effect, so community coverage of water. And basically no direct effect of having water on trachoma, and no evidence of herd protection or having higher levels of water coverage in the community. And I show this, so this shows you direct and indirect effect and total effect. I show this in contrast to sanitation, where you see that there's really no, there remains to be very little direct effect, which is the gray bars. So having a toilet doesn't actually improve your trachoma or trachoma in your family, but the indirect effect is huge. And it gets, I would say huge, it's big, and it gets bigger as the community coverage levels go up. So actually the total effect of being in a community with high levels of sanitation coverage is significant. And that's at a threshold of about 75%. And so we'd love to see, be able to look at this with regards to STH, but the data just aren't available. So as sanitation coverage in the community goes up, the impact of community coverage goes up, but there really is not much of an impact on when you have a toilet directly of impacting your trachoma. So we want to think about these things as we think about how we design interventions. This is showing, again, from the systematic reviews from the water and health, the sanitation and health guidelines, we really see very marginal improvements in sanitation. These are all showing different levels of kinds of interventions. At the top, the total sanitation campaign in India. The second grouping is community-led total sanitation, sanitation education, CLTS, and others. So we're seeing, on average, a 13% increase in sanitation coverage for an intervention. Well, that's just not going to get us there. And so we need to understand better context-specific improvements to sanitation, how we can really catalyze change up in those higher levels of sanitation coverage to really see that health impact. So what you're seeing here is a review of the gray literature we did looking at trachoma-related interventions. And all of these rows in the figure are showing kind of theoretical components that we would want to see in an intervention if we expect theoretically to see improvements. And what I want, the take-home message that I want from this slide is, so blue is that the study explicitly talked about this factor. Lighter blue is that we kind of gleaned it from reading the paper, and gray was that there was no intervention there. And so what I want you to really get from this snapshot is there are few of the interventions in the trachoma community that we reviewed that really use kind of behavioral, focused on behavioral maintenance and use behavioral theory. And I think that's one of the things that the WaSH sector and the kind of WaSH related work within the NTD sector could really focus on is driving forward on kind of more behavioral centered intervention design and evaluation. And just to give you a few just quick examples from one of our studies, here we looked at NTD related WaSH behaviors, and we used formative research to empirically derive barriers and drivers. And we didn't talk about in our intervention that you need to wash your face for trachoma. We talked about that you should wash your face because it makes you beautiful or it makes you comfortable, happy, and healthy. And those are things that were derived from formative research we did. And we found that trachoma itself was not going to be a driving factor. And the other thing is that we realized that everyone had different drivers for why they wanted sanitation. And we developed and used this household card that the different householders could design their own approach to improving their toilet. And so we weren't prescriptive in you need to first do this and then this and then this, but actually said what actually is most important to you. And the point here is to get people to build agency around improvements and feel confident that they can continue to make improvements and also resolve from setbacks such as flooding. So kind of in conclusion here, getting back to this, I think we should be beyond the point of saying, is it plausible? Is it efficacious? Is WaSH plausible? Is it efficacious? Of course it is. I think the evidence suggests that it is, but I think what we're really falling down on is the effectiveness and also how to develop context-specific programs. So I'll kind of leave us with a couple of questions. So how could we, in the NTD space, thinking about WaSH, include behavioral theory and intervention design, mainstream some NTD-related behaviors into WaSH programming that aren't there, ensure fidelity and adherence into our interventions. So how do we ensure that we're actually changing the behaviors? How do we replicate and scale successful programs, and how do we do it with rigorous methodologies? And then how do we kind of drive WaSH targeting in the NTD endemic areas? And maybe that will be discussed a little bit more later. That's a little more policy relevant. So with that, thank you so much. And I'll turn it back over to you, Yael.
Thank you so much, Matt. That was really great and comprehensive. And I can see quite a few people are hoping that we'll share the slides and the recording so that they will get a chance to go through all of this information again. So really great food for thought. And I don't think there are any questions for Matt at this time. And we will therefore move on to our next speaker, who is Dr. Anna Phillips from Imperial College. Anna, I don't know if you want to share your screen. I don't think we can see your slide yet. I'll introduce you while you're doing that. So Dr. Anna Phillips currently works at the London Centre for NTD Research, who is also leading this event at Imperial College London as the project coordinator for the Geshiaro project in Ethiopia. Apologies for the terrible pronunciation. This project aims to interrupt transmission of STH and schistosomiasis through MDA and WaSH. Anna is also the principal investigator looking at diagnostic tools for schistosomiasis in Brazil. She's previously worked at the Schistosomiasis Control Initiative, or SCI Foundation as it is now, and a principal investigator under the Schistosomiasis Consortium for Operational Research and Evaluation, SCOR, in Mozambique and Niger. Great to have you, Anna, and I will hand over to you.
Great, thank you. I presume you can see my screen now.
Yes.
Okay, so today I'm going to present on the Geshiaro project in Ethiopia, which uses biometric technology to link individual WaSH coverage with STH and schistosomiasis infection. National deworming programs traditionally rely on school-based MDA to children to control morbidity caused by these infections, but mathematical modeling has suggested that if you treat whole communities with high coverage, there's potential to decrease prevalence of infection below a threshold that infection can no longer be sustained, i.e. transmission break. However, there may be bounce back in infection over time if we don't change the environmental contamination. So the Geshiaro project aims to look to see what the added benefit of WaSH interventions are to community-wide MDA programs. The project is taking place in Wolaita zone and SNNPR in southwest Ethiopia. The target population is approximately 1.7 million people across 15 districts. The project has 3 intervention arms: expanded MDA, which is community-wide biannual albendazole and annual praziquantel treatment with a target of 80 to 90% verified treatment coverage, as well as the provision of WaSH and behavior change communication. In Arm 2, there's expanded MDA and the One WaSH national control, the national program in Ethiopia. And then Arm 3 is a theoretical control arm where it's just the annual school-based MDA, which is part of the current national STH and Schisto control program strategy. The objectives of the project are to accurately link individual treatment and WaSH uptake over time using biometric technology, and to quantify reductions in prevalence and intensity of infection by intervention, and to understand if WaSH hastens to reduce infection when combined with expanded MDA. So the Geshiaro population census includes collecting information on demographics as well as household WaSH coverage. This is a workflow whereby the enumerator arrives at a household if they agree to participate in the census. Every individual in that household is enrolled by a biometric fingerprint, and then with a barcoded study ID card. A household WaSH survey is then carried out. And so this denominator consequently allows us to calculate an accurate measure of treatment and WaSH coverage. So we carried out the initial census in one district in Gloucestershire in 2018 with a mop-up in 2019. 4 further districts were then censused in 2019. In total, around 98,000 households were registered with around 466,000 individuals. We also carried out a baseline parasitological mapping survey among 137 villages, where we took samples from a whole age range from pre-SAC all the way up to adults. And then in addition, there are annual sentinel sites that are carried out among 150 people across 30 communities. These were both carried out in 2018. And the purpose of this longitudinal survey will be to measure changes in schisto and STH prevalence and intensity over time, as well as identifying potential hotspots. So a mapping will be carried out again at the end of the 5 years to see the change over time. So expanded MDA, this is community-wide treatment with a target of 80 to 90% verified treatment coverage. So this is higher than the standard 75% WHO protocol. And it's following the FMOH, the Federal Ministry of Health guidelines, where the total eligible population for MDA will be determined by matching individuals captured in the census at MDA. So this is a flow of how we identify people at MDA, and we also at the Sentinel site. So we try and identify someone initially with their biometrics, so they would have been registered in the census. So we try and identify them again with their fingerprint. This will pull up their record, their household record, and their individual record. If that doesn't work, then we use a study ID card. And again, if that doesn't work, then we have a name search algorithm where we can try and identify those individuals. If they are not registered, then they are registered again as a new participant. So the WaSH interventions for Gashiro, although it's not necessarily helpful to separate the WaSH interventions as they've got quite interlinked transmission pathways and can't be provided in isolation from each other, here are the main WaSH efforts by Gashiro. So as part of the baseline assessment, we identified communities that had poor access to improved drinking water, and then a plan was rolled out to drill shallow, deep, or rehabilitate existing wells according to need. Likewise, a sanitation assessment was carried out, and a small business loans were created to purchase latrine slabs and latrine building services. Purchasing soap and more recently hand sanitizer were also incorporated into these WaSH business centres for communities to purchase. And finally, behaviour change communication is a final pillar to ensuring that these WaSH efforts are taken up by the community. So the baseline parasitology, so according to the baseline mapping and Sentinel site data, we basically demonstrated that we have a low starting STH and schisto prevalence. If we look at the age infection profile by parasite, as I mentioned, we sampled pre-SAC all the way up to adults. We can see that the pre-SAC, traditionally the national control programs survey the school-age children, but the pre-SAC and the adults that actually were harboring the greatest burden of infection, and really highlights the importance of considering them not only in monitoring and evaluating in an elimination context. So the baseline household survey, overall around a third of the households had access to basic water. And of those, half practiced safe water storage and handling. Basic sanitation coverage was negligible at baseline, with virtually no households having access to hand washing facilities. And exposure to fresh water sources such as rivers and waters, either through cooking, hand washing, bathing, clothes washing, which is important for schisto transmission, showed that communities had quite high contact rates with unprotected fresh water, which had implications for schisto and certainly transmission rate for that. School WaSH was very poor. The coverage, water access in the schools was very low, with negligible basic sanitation and hand washing facilities. So when we look at the change in household WaSH over time, so the initial household survey was carried out in one district in Bolososori 2018, and then followed up in 2019. And this showed that there was a 20% improvement in access to water as a result of the water interventions that have been provided. And sanitation, unfortunately, there was supposed to be a scale up of the water interventions in this year, but due to COVID, that was delayed. So we don't have more of a measurement on change in WaSH over time. We've had to take a gap from 2020. So hopefully we'll see, this is currently being implemented now, so we should hopefully see that at the beginning of next year. So what don't we know? I guess understanding the effect of different WaSH interventions, specifically in the Gishira in this Ethiopian context, and quantifying the magnitude of the effects of these interventions. Is fecal egg count a good proxy for measuring impact? That's currently what we're relying on, as well as reported behavior change. What's the impact of sharing latrines? If there is a latrine and they're sharing it, is that going to have an impact on transmission? Gender, what is the role of gender in the power dynamics on the uptake of interventions, as well as the prevalence of STH? We know from the focus group discussions that we did, so we've been doing qualitative research to complement the interventions and the quantitative research that we're doing. One of the things that the women fed back is say that they weren't comfortable going to the latrines at nighttime because there's no electricity and they didn't feel safe. In terms of trying to advocate for not using fresh water sources for washing clothes, drinking, a lot of women fed back and said, well, that was my moment to go and talk to my friends and get away from the household to talk about my husband. So just doing this qualitative research and these focused group discussions are really important in tailoring the interventions as we go along. And then identifying effective behavior change interventions. How do we measure this change? Measuring the change in routine behavior is a challenge, and how do we measure that works? And then what's the threshold? I know that Susanna touched this at the beginning, but what threshold, what level of coverage is needed for this to work? And then usage. I think something that we struggle with is we have good data on coverage for latrines. We have reported usage also for the soap, but what do we know about true usage, and how do we measure that? And finally, school attendance. How does WaSH influence this? So some of the challenges and the lessons learned for us, particularly the biometric technology has been very unique, and it's a great opportunity to track individual behaviors, and that's our next steps now, to explore that data through treatment and WaSH coverage. However, it requires a lot of sensitization in the communities and also data management on the back end as well. Hand washing was extremely low at baseline and after 1 year in the project, and it was probably not something that had been worked on enough. But what's the impact of COVID going to be on that? because that's something that World Vision, who are the WaSH implementers in this project, have really heavily been focusing on. And poor shoe use, we are measuring shoe wearing and how that could end up concentrating exposure to infection around the latrines. So I just wanted lastly to just, this WaSH algorithm, I think that Jack Grimes developed a couple of years ago, I think is really useful in terms, for schisto at least, in measuring exposure and a risk algorithm, and that's something that we would like to use to look at how WaSH exposure changes over time. So I just want to thank everybody at Empirical, EPHI, World Vision, Simprints, who are implementing the biometrics, and obviously the Federal Ministry of Health and SIF, who are funding the project. Thank you.
Thank you so much, Anna, for a great presentation. And I think we can all see there are some common themes coming across. We do have one question for you from Amadou in the chat. He's asking, was there any problem of loss to follow-up as a result of movement, non-compliance, and death?
Yes, yeah, yes, we have lost to follow-up. Unfortunately, there are issues with the biometric in the fact that young children don't form their fingerprint until they're about 5 or 6. So we have to, following them up over time is quite challenging. Sometimes if people are manual workers, their fingerprint is quite worn. Again, that's quite hard to follow people up again. So we did have to spend a lot of time cleaning the data where we thought that they had been lost to follow up, but actually having these 3 methods of identification, having the fingerprint, having the study ID card, and having the name, we're able to amalgamate the 3 sources of data to make sure that we do have that true individual. But there was thousands of people that we thought had been lost, but actually we realized that we still had them, but we had to cross-check multiple data sources to verify that.
Thank you so much, Anna. That was really comprehensive. I think that was all of our questions for Anna. In that case, we will move on to our 4th and final speaker. And that is Dr. Sarah T. Dodson from the Fred Hollows Foundation. She's the Director of Research. She's also Honorary Research at the Centre for Eye Research in Australia. The Fred Hollows Foundation undertakes and supports health services research that improves the quality, productivity and accessibility of eye care for those living in low resource settings. And Sarah T. is a health services researcher and behavioural scientist with a particular interest in WaSH for trachoma elimination and enablers of citizen participation in healthcare and health behaviour across settings and cultures. I should also say that Sarah T. is a very active member of the NNN WaSH working group and currently leads some great initiatives, one of which you'll hear about now, and the other one is developing a fantastic practice manual around behaviour change programming for NTDs. So Sarah T, over to you.
Awesome, thank you, Gail. Thanks for inviting me to speak to you today around this particular initiative that the WaSH working group are leading, and it's great to see so many people on the call. So in concluding the presentations today, we thought it would be great to kind of alert you to an initiative that the NNN WaSH working group and the WHO are undertaking at the moment, with the hopes of having you engage, because we would really love your input. So I'm going to talk you through the development of the WaSH and NTD Research Agenda that we're currently working on. So as we've already been discussing, the NTD roadmap, the WHO roadmap for NTDs is due to be launched later this year, early next year, and we'll really present for the sector a set of disease-specific and cross-cutting targets and strategies that will drive the work for the next 10 years. And it also has quite a number of calls to action for the sector stated within it. Those include the importance of making sure that we're integrating the activities, not only across NTDs, but across other sectors, and that we're ensuring that we're really investing effectively in research and development and innovation. It's really the work in that area that's going to help us elevate the impacts that we're currently having and ensure that we can achieve the targets that are set out in the roadmap. But as all of you on the call will be acutely aware, the resources that are available for research are quite limited, and there is a real opportunity over the next decade for us to up our game in relation to the way that we coordinate efforts in relation to research, and particularly operational research in this space, so that we can ensure that we're achieving the impacts that we hope to see, and really getting the most bang for our buck in terms of research investment. So in order to contribute to the achieving the outcomes that are set out in the NTD roadmap, the NNN WaSH Working Group, in collaboration with WHO, have initiated the development of a WaSH and NTDs Research Agenda. And the real kind of focus and goal of this is to ensure that we are elevating the opportunity for coordination of research activities in this space, and making sure that we're effectively targeting research investments. The intention is that we will end up at the end of this year or early next year with a clear set of priorities, research priorities for the sector in relation to WaSH for NTD research. And we're hoping that this provides a range of key audiences with a real way to focus investment. So the key audiences that we're targeting for this agenda are national programs and ministries, NGO program implementation actors and advocacy groups, researchers and research communities, as well as those that fund that work. It will have a reasonably broad focus in terms of its scope. So we're looking at not only capturing descriptive and discovery research that helps us to understand the causes and other factors that might be risks for NTDs in relation to WaSH, but also those areas of research that relate to discovery and implementation science. And we hope that this will sit alongside the NTD roadmap and help drive our work in that particular area. In terms of the group of people behind this body of work, we have a task team that is mostly made up of members of the NNN WaSH Working Group, but we do also invite others who perhaps are active in that group to participate if they're interested. And we've established an advisory group that help us to design the methodology that I'll talk you through today, as well as help us to identify and reach potential stakeholders and participants in the work, and help us to analyse and publish the results ultimately. And I'm just going to talk you through the approach that we're going to take, and then I'll show you how you can get engaged. So we've kind of done a little bit of thinking about the approach that we might take to this initiative, and looked at various other approaches to developing research agendas that have been tried by other groups in other fields in the past. And we've landed on the Child Health and Nutrition Research Initiative approach, or an adaptation of that particular approach. And I'll talk you through the steps that we're planning to take. A few kind of principles that have driven our decisions around the approach are the need to make sure that we're engaging as many stakeholders as possible, and have a quite transparent and systematic and fair process for identifying research priorities, but also the need to kind of balance the time and the investment that we have to put into this effort. And the Child Health and Nutrition Initiative methodology has been used for a range of other research prioritisation exercises in the past, including in the areas of disability and mental health and dementia. So just to talk you through the steps that we plan to take, there are 4 kind of broad steps involved. The first is the elicitation of research questions, and hoping to engage you in this step a little today. And this is really a brainstorming exercise, if you like, and involves asking as many stakeholders as we can reach to identify what they believe to be the key research gaps and research questions, and enter those into a survey. We will be reaching people through events like this, as well as through WaSH and NTD communication channels, and we'll also be reaching out directly by email to organisations and stakeholders that we identify through our task team and advisory group meetings. The second step involves the development or the undertaking of a rapid literature review, and it's not intended that this activity duplicate efforts that have already been put into lit reviews in this space, but we're really keen to ensure that we're not presenting research priorities in the agenda that are misaligned to what the evidence says. So we're keen to make sure that we're grounding this work within the context of what is already being published as evidence. So we'll be undertaking a rapid lit review. We've commenced that work already. And the third step, once we do have the inputs from stakeholders come through via the survey, we'll be doing a thematic analysis of those responses and looking to identify key themes and sub-themes that are coming through from that survey, and looking to produce a consolidated list of research questions and gaps. We'll then present those back to participants through a second survey, and we'll be asking them to assess the feasibility and the potential impact, the innovation, the potential for translation, and the likely impact on issues of equity of each of those research areas that we present, as well as asking people to assess the level of importance of that particular research question. And we'll then take the results that we garner from that exercise, analyse the results, and with the support of our advisory group, produce a research agenda, which we will hope to publish early in the new year. As I mentioned before, that we have soft launched the survey already, and I'll drop into the chat box in a few minutes the link for people to follow. We'd be really keen to get your engagement in this exercise, and you'll see some more comms coming out in the coming weeks around this, so this won't be your only opportunity to participate, but if you have some time in the coming days or during this discussion to perhaps identify and enter some of your research ideas, we'd be really grateful to hear them. So thank you, and if you're keen to kind of get engaged or to hear a little bit more, please do reach out to me. Thanks very much.
Thank you so much, Sarah-T. That was great, and I hope everyone is as excited as I am about this research agenda development. That's going to really be very helpful for the community as a whole. I think we're now going to move on to a little bit of group work, and I hope that those of you in Australia or that part of the world, you've got your coffee with you. Those of you in the UK, maybe you've got something a bit stronger, and you're ready for a fun discussion. So we're going to be breaking out into 3 discussion groups for about 20 minutes. You'll be allocated automatically to a breakout group as soon as we hit the button. One group will discuss how to gain momentum with implementers and funders. More details on that in your group. The second group will talk about COVID-19 and the opportunities that WaSH promotion has created for NTDs. And then lastly, WaSH and NTD's operational research and gaps, so to feed into the exercise that Sarah-T has just presented. So on that note, I will hand it over to Justine to hit that button. Okay, no worries. I think we're doing a bit of a feedback from the groups. So I'm wondering whether we want to take the first group first. So that was a group talking about how to gain momentum. Matt and Susanna, over to you.
Yeah, so I was saying I can start, and then Matt, can you please help if I wasn't able to kind of listen and take notes at the same time. Yeah, so we had an interesting discussion. We were around 15 people coming from different sectors, between academics and implementers, ministries of health, funders as well. And we tried to kind of separate the questions a bit, and we landed on this issue that I think has been around for a while, which is, you know, which donor base should we be targeting? So should we be targeting NTD donors to convince them to invest in WaSH, or should we actually increase the donor base and look and reach out to typical WaSH donors to have them you know, fund WaSH activities that may be more tailored to NTD control in NTD endemic countries. We did mention also a bit the problem with this approach of the fact that I guess the scientific evidence coming from intervention trials is a bit mixed, and that has maybe discouraged a bit some WaSH organizations and funders because of these kind of, you know, problematic demonstration of effectiveness of WaSH in some NTDs. Another aspect that was very common throughout all the interventions was the need for having a more effective stakeholder engagement at you know, in country. So having working groups and technical meetings with people coming from different branches or areas of the government. So having the, you know, the sanitation, the infrastructure, or the public works ministry, people coming together with, you know, with WHO and the Ministry of Education and the Ministry of Health, to really kind of spread and divide, I guess, the tasks among different stakeholders. And we've heard a few examples of countries where, in fact, that is working and successfully, I believe. Matt, do you mind jumping in and complementing anything they may have forgotten?
Sure. Just, you know, the WaSH sector is largely, I think, not driven explicitly by health, and the SDGs are really about reaching, about equity and reaching the poorest. And I think that that's where the nexus can be in the NTD side. Is I don't think the WaSH sector is there's going to be traction around explicitly focusing on WaSH for NTDs for health gains. My sense is that by focusing on a shared vision around reaching the poorest and most marginalized, that's where there may be more traction. And the NTD sector is very data rich in terms of where the NTDs are and where the NTD endemic communities are. The WaSH sector is not as good at knowing where there's poor WaSH. And so actually using NTD endemicity to drive targeting may be a good way to get WaSH investment in NTD and endemic areas.
Thank you so much, Susanna and Matt, and the whole of Group 1. With that, I'll hand over to Justine. Any feedback from the second group on the opportunities presented by the COVID-19 crisis?
Yes, thank you, Yael. We had a really good conversation about how to leverage the opportunities that are provided by the COVID-19 pandemic. We talked a bit about how the messaging around hand washing has been so effective and reached so many communities that perhaps we haven't been able to reach previously, about how communities have kind of taken ownership of that message in pandemic times and created their own hand washing stations, and about the opportunities to sustain those longer term, given that they did come from communities rather than sort of imposed from outside. We talked a lot about behaviour change and how important behaviour change is and how difficult it is. What else? We talked about needing to link projects, so sort of touching on what you've just talked about, Susanna and Matt, about how WaSH and NTDs can actually help each other, and the synergies that you can find there. We talked as well about, about funding. And I think this is something you just mentioned again around how WaSH and NTDs need to leverage different groups of stakeholders. So you need to think about environment, you need to think about economic aspects, you need to think about health aspects, about coming at it from this systems change approach. And Pauline had a really great point about using the funding that's available for COVID for sanitation. So using this moment in time as an opportunity to leverage the financing that is available for sanitation through COVID budgets, and how we can kind of like bounce off that and make it more long term. What do you think, Yael? Have I missed anything?
That was very comprehensive. Thank you, Justine. All right. So with that, we'll hand over to the third and final group. Sarity, I think.
Yes. Hey, guys. Anna, jump in if you want to add anything. I'm just going to share my screen because we used the Fun Retro tool, and our discussion was focused on what some of the unanswered research questions are in the area of WaSH and how it impacts on STH and schisto. And so you'll see some of the fabulous ideas that were generated on the board. And we kind of unpacked to some of these and discussed perhaps why people thought these ideas were important and perhaps what the next steps around them were. So I mean, some of the key themes that were coming up through our discussion were a lot around community engagement. So making sure that we have a solid understanding of what the community's needs are, what their perspectives and circumstances are, and what their ideas are for how improvements in WaSH might be progressed. And we talked a lot about some of the challenges in not just coming up with novel solutions, but having those solutions funded. There's challenges, as it sounds as though some of the other groups discussed, in engaging funders in some of these novel projects. We also talked a bit about the opportunities that NTD surveys present and how we might improve and amplify the opportunities of those surveys. And we talked a little bit too about the particular issues that women experience. So one of the ideas that was posted was around the role of gender and power dynamics in the uptake of WaSH interventions. So we discussed a little bit about some of the dynamics at play there. Anna, anything else?
No, I think that was good. I think in terms of incorporating surveys, I think the other thing that Rabina had said was like just standardizing that process, because there seem to be people collecting different things and it's actually not always clear what's relevant data to be collecting and that would be useful not only for your program but other people. And when you're doing all these reviews, that Matt and Susanna have touched on, is the fact that there's so much heterogeneity and the fact that everyone's using different methods, different outputs, and it just becomes really hard to collate that and understand what the impact of all these interventions are if we're not standardizing what we're collecting.
Great.
To you, Yael.
Thank you so much. And Group 3 definitely wins the award for snazziest breakout group. Well done. That was really impressive. Sorry?
What's our prize?
Your prize is to do more of these presentations in future sessions at unsociable hours. As you asked. All right, so that leaves it to me to, I think, do a bit of a summary before I hand over to our co-moderator Pauline for closing. First of all, I'd like to thank all of the presenters and moderators and everyone who participated and contributed to the discussion, which I think has been really fascinating. I'm not going to try and summarize everything that's been said. I think a lot of really great issues have been raised. So just a few things to emphasize from my side. And I'll be honest and sort of say that as a previous WaSH sector person infiltrating NTDs and now in the other direction, I have a few kind of bugbears that trouble me about the way that we engage on WaSH within the NTD community. So I hope you'll tolerate what I've got to say. So first of all, I think that it's clear to everyone that although there are challenges around quality of evidence and quality of studies and so on, there isn't really any doubt that WaSH really plays a really crucial role in the transmission route for the diseases that we discussed today. It also plays a really important role in the treatment and care of other NTDs. And it should play a fundamental role in the very ambitious targets of the new roadmap around control, elimination, and eradication. And I really want to highlight Matt's really powerful slide about population attributable fraction here to support that. But I think that we sometimes make assumptions within the NTD community about what WaSH looks like, what it means, and what we expect from it to deliver. And those expectations don't always match with the reality. And what we often don't think about is whether or not the intervention that has been put in place actually reduces the risk of transmission or exposure. And by not taking that into account, we don't always evaluate that. So at the end of the study, we actually don't know whether what we did could have been expected to work. I think we also tend to view WaSH as a kind of monolithic concept. We need to do more WaSH. Well, actually, as we've heard in all the presentations today, WaSH is actually quite complicated. And not only is it 3 distinct intervention areas, water, sanitation, and hygiene, but also what we mean by sanitation, for example, can be quite different. So it can be a very poorly constructed pit latrine that doesn't survive a rainy season, or it actually can be a community-wide sanitation intervention of high quality. And those two things have very different outcomes. So I think the question about thresholds that was raised by all of the presenters and also by some on the chat is really crucial. Is there a threshold, both in terms of access and of quality of service, that we need to be aiming for in order to really achieve results on NTDs? So when people ask me, and I have been asked this question, why hasn't trachoma prevalence gone down when we've improved latrine coverage from 0 to 20%? I think the answer is quite self-explanatory. So I think that you know, there is a myth, sorry, a danger that a myth has been created that WaSH doesn't work, or it's too difficult or too expensive. So we just need to carry on doing what we've always done, which is MDA or other control measures, and that means that WaSH becomes a bit of an afterthought. And that's where we really need the evidence quite urgently on what actually works, especially now that our goals and targets on NTDs are a lot more ambitious. And as Pauline said, we need that evidence in order to deliver the ambition of the roadmap and of the new global strategy on WaSH and NTDs. And then finally, I just want to emphasize one of the points that Matt talked about after the group work. I really couldn't agree more that it's a hard job to convince the WaSH sector to engage on NTDs as a health issue. What we're really trying to do is to leave no one behind, to make sure that everyone everywhere has access to good quality services and access to universal health coverage. And that is being done from an equity lens. And so it's quite reassuring to know that that is actually the thread that runs through the NTD roadmap and the global strategy on WaSH and NTDs. And I just want to leave us on a bit of an optimistic note in that having spent the last decade or so trying to get the WaSH and health sectors to work together, I think that NTDs is actually an area where we've seen a huge amount of momentum, a huge amount of collaboration and success at a country level and at a global level. And although we shouldn't be resting on our laurels and thinking that we've done all that needs to be done, that's clearly not the point. We do have a lot of successes to build on, and I hope that this meeting and what has come out of it will be another paving stone on the way to success. And success means everyone having a better and healthier life. So with that, I will hand over to Pauline for a couple of closing remarks.
Thank you, Yael, and thank you also very much, everybody. I must say that I'm very encouraged, really, by the enthusiasm that I have seen today and the momentum that you've all helped to build around the WaSH agenda over the years, and especially over the last year or several months since we started discussing the NTD Roadmap 2030. As Yael said, we have a lot to build on, and we've seen from just the 3-4 presentations in this session alone that there is quite data and evidence to build on as we move forward. We also have a lot to leverage on the opportunity that's been presented by the ongoing pandemic. And therefore, we really have an opportunity to be able to step up and be able to make an impact in terms of what we can integrate into NTD programs. I know over the years it's not been clear. It wasn't for me. Also working in NTDs, working in schistosomiasis, what I could really do, but it's becoming clear thanks to all of your work in terms of just moving the discussion forward and getting it to where it is. So I would like to encourage us to continue the conversation. I look forward to the report and the synthesized summary on all of the suggestions that we presented here. I look forward to seeing that in the main meeting and to eventually seeing some very good operational research questions going forward, and program managers being able to avail the opportunities to have this happening in NTD programs to continue to build the evidence that we all need to accelerate the progress in the control and elimination. Again, thank you so much. I've really enjoyed the session, and I look forward to the final COR-NTD meeting on this.
Thank you.
Thank you.
Pauline.
Thanks,
Yeah,
Pauline.
thank you all our speakers.
Thank you so much, everybody.
Thank you.
Everyone.
Thank you. Bye-bye for now.
Good night.
Everybody. Thank you.
Yeah.
Well done, everyone.